Okay, good morning, everyone, and thanks for joining us for another discussion in diagnosis. I'm Goutham Rao. I'm the director of the UH Advanced Center. And this morning we have a special guest, JJ Hue, who is one of our own. He's a third-year surgery resident here at University Hospitals, and also doing 3 years of research with Dr. Jordan Winter. And his future plans include becoming a surgical oncologist, hopefully with a strong emphasis on research as well. And JJ and Jordan were actually the ones who kind of turned me on to the idea of unintentional weight loss as a marker of cancer. But this morning, we're going to talk, JJ, about pancreatic cancer. Obviously well known, I think, not just within the healthcare professionals community, but broadly as a devastating diagnosis. A lot of high-profile cases, Steve Jobs being one in particular. So I was hoping we could start off by, if you could tell us a little bit about the overall burden, the incidence. We know it's rare, the prognosis, risk factors, those kinds of basic details for us.
Yeah, absolutely. And I would just like to take this time to personally thank you, Dr. Rao, for this invitation. Thank you all for joining me here today. Just looking at the past folks that have spoke at these meetings, it's a real honor to be here chatting with you guys this morning. So, like Dr. Rao said, I spent the last 3 years in the lab working on different aspects of pancreatic cancer, both some bench work and also some outcomes research and some risk factor associated studies as well. So I'm happy to chat with you all. So specifically about pancreas cancer. So this is one of the top 10 most common cancers here in the United States. The incidence yearly is around 65,000 people. So it is, on the rare side, but it's certainly a little bit more common than something like cholangiocarcinoma or other HPV related cancers. I think one of the more interesting things is that at this point in time, it's actually the third most common cause of cancer associated mortality. So although it is rare, it does have a really large impact on cancer associated deaths. Some studies have actually shown that by 2030, so just a couple of years from now, it'll actually eclipse colorectal cancer and will become the second most common cause of cancer-related mortality, second only to lung cancer. So obviously, this is a big problem that there's a lot of people working on trying to figure out different ways to treat this disease. Some of the risk factors, I think, go along with a lot of other cancers. Things like obesity, tobacco, really are some of the main risk factors, but also some other fairly common things like diabetes. Some folks have a positive family history, but pretty rare. Diets that are high in processed meats. Some races are a little bit more likely to get pancreatic cancer. And then probably one of the more common things, or the more directly related, are folks that have recurrent episodes of chronic pancreatitis are at a slightly higher risk of developing pancreatic cancer. You talked a little, or you want me to talk a little bit about the prognosis? I think, like you said, there have been some high profile cases. Steve Jobs, Alex Trebek, so this is sort of in the news. Some progress has been made. So I always like to look at the studies by Siegel. The overall 5-year survival rate for all comers with pancreatic cancer as of 2023 is 12%. That's pretty dismal, just looking at that. So just about 1 out of every 10 patients will survive with pancreatic cancer for 5 years. That has actually doubled over the last decade. So back in 2012, it was only 6%. Progress is better than none. I think a lot of us would like to see that be 60% rather than 6%. But so we are making some strides. I think the biggest point of this is that most patients present with metastatic disease, and their survival remains abysmal at just a 5-year survival rate of 3%, which has remained stagnant over the last 10, 15 years or so. So we always, in the papers we write, we like to say this is the most deadly of the common cancers. And then there are a couple different subtypes of pancreatic cancer that we worry about. The most common one is pancreatic ductal adenocarcinoma, PDAC, or whatever else you want to abbreviate it as. This is the most common and what most people think of when they think of pancreatic cancer. There are some other lesions that are either malignant or have malignant potential, such as neuroendocrine tumors. So those are both the functional and the non-functional ones. The functional ones being things like your VIPoma, somatostatinoma, insulinoma, gastrinoma, glucagonoma. So a lot of the omas that are, have their own associated symptoms set with those. The IPMNs, or the intraductal papillary mucinous neoplasms. And then there's a lot of other cystic lesions that are a little less common, but still something that we worry about. All of these have sort of varying malignant potential based on size, based on some of the fluid actually within the cyst. So I think, this brings up the good point of all of these folks should probably have some form of a multidisciplinary team gastroenterology, primary care, surgery, radiology, just to really analyze these things and see who needs a pancreatectomy, who needs a biopsy, who can just be monitored. So that's a long-winded answer to kick things off, but you'll see I like to ramble on, so you can always
No,
sort of
appreciate it, JJ.
flash the red
So
light, and I'll cut it short.
that's a wealth of information. So looking back, so I've been a primary care doc for about 25 years, and I can remember maybe less than a handful of cases where I've been involved in the diagnosis. And perhaps that's because a lot of these people are presenting more acutely into the emergency room setting or whatever. And the presentation is highly variable. Just somebody who doesn't look well, unintentional weight loss, abdominal symptoms, nausea, vomiting seem to present. And then at some point you say, well, there's something going on. Let's get a CT scan, and then leads to the eventual diagnosis of pancreatic cancer. But can you talk a little bit more about how these people typically present?
Yeah, I think you hit the nail on the head where it is quite variable. And a lot of times these are vague symptoms where it's just something is off, and these are almost found incidentally. For us, like, the textbook answer is painless jaundice. So these folks come in just, usually it's their spouse or a family friend or someone says, hey, you look really yellow. But a lot of times it's so sort of insidious that patients don't even recognize it themselves. But so that along goes with that would just be dark urine, acolic stools. Important to note, this only occurs for cancers in the pancreatic head, causing a biliary obstruction. So anything in the tail, usually cancers in the pancreatic tail actually have worse stage for stage outcomes, just because they do typically present later because you lose that ability to have the painless jaundice. This importantly is associated with poor outcomes just by itself. So folks that present with or without painless jaundice do better or worse depending on. So folks can have abdominal pain, although the classic is painless jaundice. You can have some invasion of the celiac plexus, which can cause sort of this chronic achy abdominal pain, mainly in the epigastric region. One of the things that always comes up is someone that has very, very well-controlled diabetes, then all of a sudden it's very hard to sort of keep their sugars under control. So either new onset or worsening of existing diabetes should be at least sort of a subtle tip-off of maybe something else is going on. Some folks, especially with a high tumor burden, can get signs of pancreatic insufficiency. So mainly sort of issues with tolerating diet, some crampy pain, steatorrhea, stuff like that. Dr. Rao, you brought up unintentional weight loss, which is my baby. So we did a study with Dr. Rao's help here of our patients presenting with pancreatic cancer at UH. Just looking back at their actual raw weight data in the EMR, about 75% of these folks had greater than or equal to 5% weight loss over the preceding year. Again, these are sort of slow, subtle trends. They're not usually dropping, 100 pounds in a month, but just sort of these are slowly occurring. But 75% is, a good chunk. I saw another study that quoted up to 90. Importantly, one out of our several hundred patients had weight gain in the year prior to. So if you have a patient who's gaining weight, you can almost assuredly say, well, at least you don't have pancreatic cancer. Mm-hmm. I think a lot of times unintentional weight loss is probably overlooked, especially as the obesity epidemic sort of rages on. Weight loss is a lot of times thought of as a good thing. But the folks that are coming in with a new hole drilled in their belt or their pants are sagging or something like that, if they're not trying to lose weight, like as I'm sure we all know, weight doesn't normally just kind of melt off you. But some of these bad cancers, esophageal cancer, pancreatic cancer, all these can cause some weight loss. We will talk about a little clinical trial we have starting soon, a little bit later on today. Sure. But one of the other things is that a past study that Dr. Rao pointed out to me is that like 60% of people that present with unintentional weight loss, it's overlooked both by themselves, by people in the emergency department, by primary care docs, by surgeons, by everyone. Just because it is one of those signs that may not be the most obvious, and people usually don't bring it up. Some of the other more subtle things that actually some of my research in the lab dealt with was new onset anxiety or depression. So there's actually a really interesting paper back from 1931 in JAMA that said, it was a case series of 4 patients where some form of like new onset anxiousness or anxiety or feelings of impending doom were actually the first symptom of pancreatic cancer. So one of my research projects actually looked at, pancreatic cancer as an upregulation of a certain enzyme, which hijacks the breakdown of tryptophan. So it shunts it away from things like serotonin and melatonin and actually generates like anxiogenic and, or certain metabolites that are related to depression. So again, these folks that are coming in with just something's different, they seem a little bit down in the dumps, very subtle, but these can be going on. And so a lot of these are quite vague, like we just talked about. And so I think that in and of itself leads to some of the poor outcomes. In 2023, about 47% of folks are presenting with metastatic disease. Back in 2012, that was 53%. So we really have not done a good job of trying to catch these folks early. And we can talk about it a little bit, but the treatment for metastatic cancer is, for the most part, just chemotherapy. This isn't like colorectal cancer or something where we can do metastasectomies and try and reduce disease burden. It's mainly just multi-agent chemo. And it's really just not effective. Our lab studies a lot of things on trying to make novel therapies, as do many other labs. But folks with metastatic disease, really, if they make it past a year, that's sort of like everyone jumps up and down, because that's a really good outcome. But obviously, we would like to see that much higher than that. So early detection, I think, is the key.
Yeah, so let's talk about surgery, because there are some cases that are operable. What determines whether a lesion is operable or not?
Yeah, it's a good question. The first thing right off the bat is metastatic or not. I think maybe as systemic therapies get better, there's a chance later on in the distant future that we could be operating on metastatic pancreatic cancer. But for the most part, if there's a liver lesion, a lung lesion, peritoneal spread, anything like that, those patients are just systemic therapies. So that's sort of the first major deciding factor. These are big operations. A Whipple or a pancreaticoduodenectomy or a distal pancreatectomy are not benign operations by any means. These are long cases that a patient needs to be able to tolerate this. So that's performance status, comorbidities, their frailty. And then for folks with truly localized disease, we care a little bit less about, is this stage 1 versus stage 2, but it's more sort of their resectability. And so there are a couple of different staging systems, but for the most part, people will talk about this is upfront resectable, meaning there's no real involvement of the SMA, of the portal vein, of the SMV. As we get more and more encasement or abutment of some of these major vessels, things become sort of borderline resectable, or what we would call locally advanced unresectable. Some centers, we do a little bit here, but we'll actually do some vascular reconstructions. And so if these tumors are invading, say, a segment of the SMV, we'll take out a portion of the SMV and do some reconstructions. Again, that just adds more complexity, more time on the operating room table. So patients really need to be sort of primed and ready for this. Most patients now are trying to get neoadjuvant therapy. We mainly treat pancreatic cancer as a systemic disease up front. Surgery obviously has sort of the best survival outcomes, but we need to get systemic therapy in there as well. Because these are such big operations, it really kind of not about 30 to 40% of folks will never recover well enough to get chemotherapy. And so we try and do that up front now for most cases, unless there's some emergent need to go. These folks still do not do great even after surgery. We don't really talk about cures with pancreatic cancer. We talk about, hey, we made it to 5 years. That's long-term survival. Some folks will make it out 10 years. Some folks will never actually recur. But for the most part, this is a systemic disease, and people will recur slowly over time. That's, I think, why early detection is so critical, and that getting people to the operating room does have a major survival benefit compared to just chemotherapy alone. But we still have a lot of work to do.
Sure. So let's talk a little bit about that. So you and I and Dr. Winter, as well as Kelsey, who's on the call today, we've been very interested in unintentional weight loss. And as Dr. Winter pointed out, even if it's not pancreatic cancer, it's usually something. So Kelsey and I spent a lot of time trying to distinguish between unintentional and intentional weight loss, just because so many people in our society obviously could benefit from weight loss, and that's been difficult. And that's a useful screening tool. It'd be wonderful if everybody weighed themselves every single week or so and then kept track of that. That's probably one of the most important things that they can do. But are there additional screening tests, maneuvers that we could consider?
Unfortunately, the short answer is kind of no. There's no real single test for pancreatic cancer. Just looking at sort of the major healthcare networks, the NCCN, the United States Preventive Service Task Force, they really say there's nothing that we should be doing just as a broad screening for folks out in the community. There are some things in the work. I think one of the interesting studies that we quote in a lot of papers is that someone sort of tracked the genetic mutations that occur throughout the course of pancreatic cancer development. And these really develop over the course of like 10 years. They go, through different stages from, pre-malignant to the pan-ins to something that's, in situ, and then, on to invasive cancer. But there is a broad window that we have time to find these things. It's just we don't have the current technology to do so. Current imaging technologies a lot of times will miss things that are under a centimeter. Especially folks presenting to the emergency department, to their PCP or whatever, usually are not getting triple phase pancreatic protocol CAT scans, right? They're getting a kind of standard CAT scan with IV and PO or just IV contrast, which will miss a lot of these tumors. But there is a window that we have some time to look into. The doubling time for these tumors to go from like a T1, which is less than 2 centimeters, to a T4 is about a year. So again, like these are sort of, we think of this as like this crazy rip-roaring disease where you have it and you're metastatic the next day. But these are really sort of slow growing. We just have to find a way to intervene on them earlier. I think I've probably hit the nail or beat this to death already, but this lack of an effective screening is really what's kind of leading to such poor outcomes. We can't find this early enough, so we're seeing it so late, and then we just don't have effective therapies at this time to treat that disease. So we're still sort of looking for that magic bullet of how are we going to pick this up early.
So let's talk about the cutting edge a little bit. There's been a couple of studies that have come out recently. One from Penn. Recently, a couple of days ago, there was a study of molecular genetics, different biomarkers for pancreatic cancer from the University of Pittsburgh. And we're hoping to have the lead author of that study as one of our guests sometime in February. But talk to us a little bit about the GRAIL trial in particular that you're involved in, that I'm involved in as well.
Yeah, absolutely. So GRAIL is sort of, I would probably say one of the liquid biopsy companies that is probably furthest along and has had the most rigorous testing. So they look at different blood samples and look at cell-free DNA signatures, and they can basically sort of assess based on the molecular profiling of that. They can sort of spit out, hey, we think you might have a cancer, and also it's maybe most likely would be pancreatic, or actually this signature is most consistent with colorectal. So sort of a pan-cancer screening, which is really nice. They've had a few trials that have been published. Probably the most well-known is the Pathfinder one. The data are actually quite supportive of doing this. The issue is that you have to screen, about 100 patients to get a single positive cancer signal. And even then, not all these patients will have a cancer, obviously. And so these tests at the moment are well over $1,000 a piece. So if you think of trying to do that for the general population longitudinally, it's sort of not feasible from a monetary standpoint. So what we're hoping to do is sort of tie in a few of these things that we've been talking about today. We think that these folks with unintentional weight loss, they're known to be at a high risk of cancer, not only pancreatic, but a lot of cancers will cause unintentional weight loss. We did a feasibility study previously where we asked folks just to weigh themselves on a daily basis, on a weekly basis. And the results were actually quite striking. Like 90% of folks participated, 75% of all possible weights over the course of 6 months were recorded. And so we partnered with Fitbit. We're going to do a trial of 1,000 patients here at UH. We're going to give them a Fitbit smart scale that'll be synced up to their phone and also synced up with our sort of study team. Every week, hopefully for 3 years, they'll step on a scale. Their weight will be automatically pushed over, and we'll analyze it in real time. That way, we can detect if a patient's weight is dropped. Our threshold will be that 5% from their baseline weight. We can detect that in real time. So if a patient, over the course of, say, a few months has slowly drifted down, we'll be able to detect that right away. That, we out of 1,000 patients, we suspect we'll probably find about 150, maybe 200 folks with weight loss over 5%. We'll sort of go through a few steps, make sure that it is truly unintentional, that, they didn't start a diet and exercise. But this sort of high-risk group will get the GRAIL test. Of that, we're hoping to sort of enrich that population. And that way we don't need to screen 1,000 folks to find one cancer, but maybe just 10 or 15 or so folks to find a cancer. So in this study, based on some back of the envelope math, we're hoping to find 30, maybe 40 occult malignancies that otherwise would have gone undiagnosed. So we're really excited about this. We're sort of in the final phases of getting everything set up. We have funding from GRAIL, Fitbit's on board. So we're sort of just putting the pieces together. these are just going to be sort of all comers in sort of that age group that's high risk for cancer. So between 40 and 80. Otherwise, there's really no major exclusion criteria, just people that are willing to participate in this. And it's, fairly, I would say, rudimentary technology, right? Like weights are sort of one of the easiest things to track, probably easier than blood pressure or a finger stick glucose that people do at home. So we're really excited to sort of get this off the ground, and we'll be asking for a lot of help from the Primary Care Institute for folks out there of trying to enroll patients. And we think, hopefully we can find some cancers early and get them on treatment a lot earlier than they would otherwise.
Thank you, JJ. And the trial that JJ was referring to, where we asked patients to weigh themselves weekly, was actually done with my patients, I think, specifically. And you would say, well, it's an underserved community. It's a lot of older folks. Are they really going to weigh themselves every week? And the answer is absolutely yes, they did. There was a small monetary incentive, but I don't really think that was the goal there. And we did pick up a few cases of unintentional weight loss, and one that was a potentially suspected malignancy, and 3 or 4 others that were other conditions. One of the things I think that we have to emphasize is that people do weigh themselves every week, and you do detect unintentional weight loss, even if it's not malignancy. Maybe it's depression. Maybe it's social isolation. Maybe it's something else that a physician or someone else should inquire about. So that's why it's such a critical and such a simple marker of health overall. So thank you, JJ. I think we have a few minutes left. At this point, we're going to throw things open to our audience here and see if you guys have any questions or comments to make.
I think so. Someone threw something in the chat, which I can just address quickly.
Sure.
They say, can we assume weight loss in all cancers have the same mechanism? For the most part, I would say yes. So cancer is sort of a hypermetabolic state, along with sort of cancer-related cachexia. So, there have been some review papers that show that not just sort of GI cancers, but lung cancer, other things like that can also cause unintentional weight loss. Obviously, things like esophageal cancer or gastric cancer, where there's an actual mechanical blockage where people can't eat because of that, those have sort of an additional mechanism of unintentional weight loss. But for the most part, it's sort of this underlying hypermetabolic state that sort of increases your likelihood of having unintentional weight loss. So I think it all is sort of related to some degree. Some specific cancers may have some additional factors as well.
Thank you, JJ. Any additional questions or comments?
Hi, this is Mary. Great work. Very exciting. I was curious, in the study, did you cue the patients to weigh themselves, or was it just that they were told to weigh themselves weekly?
So for our original feasibility trial, they basically just got a text message every week that said, please weigh yourself. And they, this was sort of a very crude representation of this, but they would basically text back with their weight. So there was a little bit of friction there, in that they just had a standard like $15 analog scale. They would have to step on it and send it, manually text back. The Fitbit one, they will still get some form of automated flag if they need to weigh themselves. But they'll just have to step on the scale and it'll automatically be pushed over. So we upgraded things a little bit now that we have sort of a positive signal from the first one.
Great.
So,
and it might be neat too to do, just to do a little qualitative additional inquiry with the patients to determine barriers and facilitators, just to get it a little bit more deeper dive into the factors of adherence. Absolutely.
That's a great point.
It's a great point, Mary. And it's interesting, some of the barriers we might have anticipated, these are for the most part older patients that I have in my practice. And one was, well, are they able to text back? Do they text? The answer is absolutely yes. They text a lot. They text their grandkids, they text their kids, they receive texts. So that wasn't an issue. They got a free scale, which I think was somewhat of an incentive too, along with the payments. So worked quite well overall, I would say. Any additional comments?
Yes, I'll just put out a brief comment on a case, a person I saw yesterday, 75-year-old man whose home care nurse had called me and said, he's really losing a lot of weight. And he's got an appointment to come and see you. He had, in fact, gone from a BMI of 35 to 25 over about 5 months, and reported that he had a trip and a fall, which seemed legitimate. It wasn't a loss of consciousness or anything else, just an accidental trip. fell and broke some ribs. And since that time, things went downhill in so many different ways. He couldn't get to the grocery store. So he says, I haven't had enough to eat. I'm tired of my own cooking, and I feel like I'm depressed again, because he has been depressed in the past. And he says this holiday time is always bad because my kids have so many needs, and my grandkids. And I'm really, running around getting them from school and giving them money here and there. So he just had a kind of a big sigh, but he said, but I'm fine. I don't have anything wrong with me. I just lost my weight. And I kind of like the weight that I have now. So I couldn't, review of systems, nothing to find. Physical exam, nothing to find new. And so I couldn't resist doing some screening, little bit of general labs, but I was thinking the whole time, what am I really looking for? I'm going to get him hooked up with our community health worker to try to get him some older companions so he could have a little more social interaction. And he really didn't want to have a food for life referral or any kind of referral for anything else. He says, I'm fine. I just lost some weight because I was stressed. So the question, of course, is when you have someone, they've had that weight loss, it's unintentional, but they seem to be able to explain it, and there's really no leads at all. What would you recommend we do as a kind of enough of a workup to exclude some of these horrible causes that you've been talking about today?
So Dr. Marshall, maybe I could address that first, and I'll let JJ to have a few words. So that is our intention with the Advanced Center. The first major pilot project is about unintentional weight loss and best practices. And unfortunately, there are no best practices. The guidelines that are available in both in the UK and here in the United States are based on the opinions of one very prominent internist who wrote a wonderful review article JJ and I have probably looked at many times. But it's just, hey, get a CBC, get a TSH, ask about depression, but we don't know how useful those markers are. The other thing, Sybil, I think that you pointed out is people with unintentional weight loss tend to downplay it. Oh, I'm fine. I'm this lady who came to see me a couple of weeks ago. It's no big deal. Things don't taste as good as they did. And so that's not unusual at all. The one recommendation I could make is, rather than shooting in the dark, after you've done a careful review of systems, is to have them reweigh themselves to see if this stabilizes or not. But I'll see if JJ has some additional comments before we wrap up.
Yeah, I think hopefully with this trial, we'll sort of be prospectively looking at sort of this pathway of what we're going to do. So it'll start out exactly as you had, right? History and physical exam, careful review of systems, some basic lab work like Dr. Rao mentioned. I think if these folks have not had their recommended screening for cancer, so if they haven't had a colonoscopy in a while, if they haven't had a pap smear, they haven't had a mammogram, sort of within, I would say a fairly recent time, that's something that we should be considering. I think the review paper by Wong that basically says imaging is sort of plus minus. It's sort of up to you. And so they say you can start with something like a chest X-ray. You can start with an ultrasound, CAT scan if you think there's something there. It's a hard thing to work up. I think this GRAIL test will be really helpful. I think just even in the evaluation of unintentional weight loss, I think knowing cancer, no cancer is certainly a good first step. But there's a lot of other things that can cause this, including just things like you were talking about, just stress, a lot going on, one thing led to another. If you're asking me if I would get some form of a CAT scan for him, I mean, if he fell and had some broken ribs, I think, it may be good to take a peek at that. But it's hard for me to say, yeah, absolutely get a CAT scan, IV and PO contrast, abdomen, pelvis with chest. It's a hard thing to look at. But I think, that patient should just be high on all of our radars as far as if this doesn't rebound, if he continues to sort of not come back up. I think that, whatever that time frame is, a month or something like that, that patient, I think at that point buys himself a CAT scan.
Yeah, and I can tell you, Sybil, that we just submitted a paper on unintentional weight loss, looking at electronic health records and looking at physician practices. And so many physicians order a TSH on these patients. Not a single one was positive. Not one was abnormal. So that's the kind of state of the art we're at right now in terms of guidance. We just don't have great guidance. Okay. Well, thank you so much, JJ. Fascinating discussion. We've actually run a few minutes over, which isn't necessarily a bad thing. And thanks everyone for joining us. And we will see you all next week as well. Thank you.